All right, good morning, everybody. In the interest of everyone's time, I'm going to go ahead and get us started. Welcome to the April edition of the DuPage ROSC presentation series. I cannot believe it is April already. Wow. But here we are. Thanks, everybody, for being here. If this is your first time at one of these presentation series meetings, what we do with these is take some time to get into a topic that gives us a little bit more time to breathe and maybe foster some discussion on something. If you attend our usual ROSC Council meetings, you know that some of those presentations are a little bit shorter because there's usually a ton of stuff that we have to cram into those meetings. So this is a chance to kind of just talk about some things along the recovery continuum, talk to some people that are working in the field, and just stay up to date on what kind of the latest trends and treatments are in our area. So we're glad that we can have everybody here today. Before we get started with the actual presentation, I do want to share a couple of things for some upcoming events and programs. So let me do this real quick. Actually, you know what? I'm going to do that at the end, Marissa, because I think while you're still sharing, I can't. So why don't I keep it with you, and then I'll share my stuff at the end. How about that?
Okay. Okay.
So yeah, so our presenter today, we're very, very happy to have with us Marissa Kirch, who is the program director at Stonybrook Center in Wheaton. Marissa's been coming to our meetings for a while. She's been a great partner to our organization. And in fact, Stonybrook Center is one of the sites where they host one of the Narcan boxes that we partnered up for, which is really, really cool. We're glad to have them in that partnership. But also just having people that work in MAT come to these meetings and kind of talk about the work that they're doing, just because MAT has changed so much over the past, 10, 15 years, some of the options that are available. One that kind of has always jumped out at me, and specifically is methadone. And methadone's been around for a while, like much longer than some of the other MAT options like Suboxone and Vivitrol and things like that. But in my mind, just in the work that I've done in the field and the people that I've talked to who are in recovery, sometimes methadone still gets a lot of stigma and a lot of bad rap attached to it for various reasons. I think it's kind of a maligned version of MAT, but it is still helping a ton of people who are struggling with substance use challenges, especially opioid use disorder. So Stonybrook does a little bit of all of that. And so we are glad to have Marissa here with us today to talk about that. And then if we got some time at the end, we can hopefully have a little bit of a conversation. And then I will share some upcoming events and stuff, or if you've got a program or event or collaboration you want to talk about, we can do that at the end. So Marissa, thank you so much for being here. I will turn it over to you.
Okay, awesome. Well, we're going to talk about medication-assisted treatment today. Like Jared mentioned, I will focus a little bit more on the methadone and just give you some overviews of Suboxone, Vivitrol, just so you can kind of understand what they all are and how they kind of interact or work differently. So just there we go. Just can you still see the screen or no? Okay, yep, perfect.
We're good.
You see my background's up? Okay, perfect. Just a little bit about me. I have my master's in social work, my licensed clinical social work, and my certification in drug and alcohol counseling. I've been working in the field of addiction for about 15 years total, and have had my clinical license for about 10. So I've been doing this quite some time. I did some work at Timberline Knolls early on, working with addiction, eating disorders, self-harm, women of all different walks of life, and then did some work over at Gateway Foundation in their outpatient addiction, and also in their child and adolescent program for bilingual Spanish-speaking kids, which no longer exists, but did that for a while. And then I spent the last 8 years at Northwestern Medicine Ben Gordon Center, 6 of which I was manager of all of their addiction treatment programs, including a women's sober living house, outpatient addiction treatment, intensive outpatient, oversaw mental health court, drug court, and drug and alcohol education in the school systems out in DeKalb County for, like I said, a total of 8 years out there. And then I've been at Stonybrook Center about a year now as the program director here. So in terms of some just basic definitions for you guys, so you know kind of what we're talking about today, medication-assisted treatment refers to any treatment for opioid addiction that includes medication. So for example, methadone, buprenorphine, naltrexone, that has been approved by the FDA for opioid addiction treatment. And then we have opioid treatment programs, which is what Stonybrook Center is. And so those are accredited programs with certification from the DEA to administer and dispense opioid medications that are approved by the FDA. And just a side note about OTPs. OTPs must offer adequate medical, counseling, vocational, educational, and other types of assessment and treatment services. They can provide that on site or by referral to other agencies or practitioners. So for the most part, Stonybrook does a lot of that on site, but we do have some, partnerships that we refer clients to other services for. So one of the unique things about Stonybrook, maybe in comparison to some of the other OTPs, is that we do basically dual enroll all of our clients in either IOP or level 1 addiction counseling, in addition to whatever MAT program that they're doing. So we are pretty heavy on wraparound care and engaging in some level of counseling or support. We also offer, MARA, Medication Assisted Recovery Anonymous, at our facility as well, if people are more interested in peer support versus formal counseling. And just a couple other definitions we'll want to know. So you might see some references to long-acting opiates. Those are opiates that are slower acting with a longer duration of pain relieving action. So for example, methadone is a long-acting opiate. Some of the other ones, fentanyl, morphine, oxymorphone. And then we've got short-acting opiates, and those are opiates that are fast-acting with a short duration. So tramadol, tapentadol, mucosal, fentanyl, and then buprenorphine products. And then OUD, you'll see shortened for opioid use disorder throughout. So types of MAT treatment. We've got a couple of different types of methadone treatment here that sorry, wrong screen. I'm looking at a different one. Benefits of MAT. So MAT improves patients' health and wellness by reducing or eliminating withdrawal symptoms. So methadone and buprenorphine both do this. They reduce or eliminate the withdrawal. Methadone, naltrexone, and buprenorphine, all three, they can blunt or block the effects of illicit opiates. And all three also reduce or eliminate cravings to use opioids. MAT is effective. Lots of studies have shown that it's effective. Methadone, Vivitrol, and buprenorphine were all found to be more effective in reducing illicit opioid use than no medication. And methadone and buprenorphine specifically have been associated with reduced risk of overdose death. Okay, so now the types of MAT treatment. So for opiates in particular, there are different types of treatment that you can provide in your setting. So first, we got medical management. This is where essentially you're providing medication with brief supportive counseling, monitoring of the drug use and medication adherence, and providing referrals when necessary to other services. Primarily at Stonybrook, we do medical management. Secondary, we've got maintenance. So that's providing the medications and supporting the recovery process, but without a specific endpoint. So essentially that maintenance of the medication piece. We do some of that, but primarily we're doing more of that wraparound care here. And then medically supervised withdrawal, which was formerly called detoxification. And that's basically using a medication to help the person discontinue illicit or prescription opiates. And that is typically not recommended, as it doesn't generally have long-term results that are helpful. But there are circumstances where somebody might need to do a medically supervised withdrawal. Like, for example, if they were going to be going into a setting where they can't be using substances and they can't be using methadone or, buprenorphine or anything like that, then they might need to do this. So it's very short term, and it's basically using those medications to help them get off the illicit substances safely and quickly. So we don't typically do much of that here unless there's some sort of emergency situation, or if the client is like demanding it, essentially. Those are really the only times that we'll do that. So there's a couple different stages of opiate withdrawal that are good to kind of be aware of. We have grade 1 withdrawal, and that's an early withdrawal that for short acting opiates is about 8 to 24 hours after their last use. And for long-acting opiates, it's about 36 hours after their last use. And so with that, you'll see things like lacrimation and rhinorrhea, which is like the running nose, diaphoresis, yawning, restlessness, insomnia. Those are kind of those grade 1, you know, just uncomfortable symptoms that they first get when they're not using the opiates anymore. From there, it can progress into a grade 2, which is still an early withdrawal. And once again, is kind of in those same time frames, but then you might see those dilated pupils, the piloerection or the goosebumps, muscle twitching, myalgia. I'm going to mispronounce all of these, but the other pain and discomfort. And then after that, we're going to go up into a grade 3, and this is more fully developed withdrawal. So for short-acting opiates, it's 1 to 3 days after their last use. For long-acting, it's 72 to 96 hours after their last use. And that's where we can have tachycardia, hypertension, fever, anorexia, or extreme nausea, restlessness, etc. And then grade 4 is your fully developed withdrawal. So for short-acting opiates, that's going to be 1 to 3 days after your last use, and for long-acting, 72 to 96. So same time frame, just a little bit more severe, with more of that diarrhea, vomiting, dehydration, hyperglycemia, hypotension, being in a curled up position, kind of those very extreme symptoms. Now, for withdrawal, for short-acting opiates, it can last about 7 to 10 days, but for long-acting opiates, it can last 14 days or longer. So it's a long time to be feeling really awful. So, you know, there are some things that we can do for those symptoms in addition to using MAT, but there are some other medications that you can prescribe to help with some of those symptoms. So you can see, like, for nausea, diarrhea, anxiety, etc. These are some things that might help the client. We call those comfort meds if they are going to be experiencing withdrawal that isn't fully managed by medication-assisted treatment, or if they're not doing medication-assisted treatment. MAT works essentially by looking at kind of this intrinsic activity. So the degree of the receptor activation that's due to the drug binding. So for MAT, there are these 3 different types. We've got full agonists, partial agonists, and antagonists. And for full agonists, basically the effect of the medication or of the opiate increases as the dose increases. So for methadone, for example, the more methadone you get, the more effect you're going to feel. But it's a long-acting opiate, so it's not going to give you like the highs and lows where you're like up and down like it would be if you were using like fentanyl or illicit opiates. Versus buprenorphine, which is a partial agonist. So the partial agonist has like a ceiling effect. So in the beginning, the more you take, the more you're going to feel, but then it's going to kind of taper off at a certain point. And then an antagonist, that's going to bind to that opiate receptor, but it's not going to stimulate the receptor at all. So you're not going to have any effect if you're taking an antagonist like Vivitrol or naltrexone. So methadone, it's been proven to be highly effective. It's shown to increase treatment retention, to reduce the misuse of opiates. It can reduce drug-related HIV risk behavior and decreases the risk of overdose death. Like I mentioned, it's slow in onset and long-acting, so it avoids those highs and lows of short-acting opiates. It's an oral medication. Typically, it's given as a liquid, concentrate, a tablet, or an oral solution that is taken daily. So here, ours is liquid. We do liquid methadone primarily because it's easiest to keep track of. You don't have to worry about like, oh, I dropped a pill. Where did it go? So we have fancy dispensing machines here that, you know, the computer tells the machine exactly what to dispense, and it dispenses that amount of liquid into a cup. Same with like if they were going to get take-home medication, it would dispense that amount into each bottle. And so they would have a different bottle for each day that they are doing take-home medication. And essentially, once again, it blunts or blocks the euphoric effects of any illicit opiates because it's already on the opioid receptors. So they're going to, yes, feel something from it, but they are not going to have those highs and lows that they would feel from other opiates, and it blocks some of those more dangerous opiates like fentanyl and things like that from attaching. Okay, so the criteria for methadone, you need to meet criteria for having an opiate use disorder. I had to revamp some of these slides because a lot of the rules just changed. April 2nd, the federal rules have changed on some of the criteria and things loosening up a little bit to allow greater access. But essentially now it's kind of narrowed down to you need to meet criteria for an opioid use disorder, and you need to give informed consent for that type of treatment. The highest priority in patients still are women who are pregnant and patients that are within 6 months of release from incarceration or an abstinence-based setting. And essentially the reason for that is if you're coming from an abstinence-based setting or from incarceration where you haven't been using for a while, you're at a great risk of opiate overdose. So if you go back to use, you're much more likely to overdose if you're coming from one of those settings. Contraindications, we probably wouldn't want to give this to anyone who obviously has an allergy to methadone or who has other respiratory depression issues like asthma or sleep apnea, things like that. It is a sedative essentially, so we don't want to mix this with other issues related to respiratory depression. Methadone, the effectiveness of it is that it retains patients in treatment. It reduces the illicit opioid use more effectively than a placebo, also more effectively than the medically supervised withdrawal, which was that short-term treatment we talked about, or no treatment at all. It is one of the largest, most evidence-based treatment approaches to opioid addiction. And studies have also shown that it is associated with lower rates of cellulitis and it reduces criminal behavior. Some of the risks, we talked about respiratory depression. Typically, this risk is highest during the initial dosing and or dose titration, and with concurrent misuse of any alcohol or benzos. So anything else that might impact your breathing, respiratory, it can be extra dangerous to mix it with those. Something I found interesting when I started at Stonybrook, because I didn't know a whole lot about this before, was that it's not as dangerous, for example, if they're using cocaine with it or even like fentanyl, but when they're using alcohol or benzos, that is the most dangerous combination with it. Since 2006, it does have an FDA black box warning for QTC prolongation. So we do EKGs on all of our clients to look for anything that we see that might indicate that there may be a lethal reaction. So once again, if you have heart problems or respiratory depression issues, you want to make sure that you're safe to take this. Obviously, accidental ingestion can be fatal, especially for children or people who don't have a tolerance to it. And so for that, we focus very highly on how to store take-home medication safely. Making sure it's locked up at all times. We require all of our clients to have a lockbox to ensure that it's not going to be accessed by the wrong people. Neonatal abstinence syndrome, this can occur in newborns of mothers that are using methadone. It's very treatable from the hospital setting, and sometimes they don't even really need any sort of medication treatment or anything if they're born with this. There are some other things that they can do, like keep the room a little bit darker, provide a lot of like nurture, comfort, support to the child and or to the newborn, and typically that could be enough. So it does concern people, but that is a lot less risk to the baby than should they overdose while pregnant or use illicit substances while pregnant. Also, you can have a physical dependence to methadone that obviously can happen when you're using any sort of opiate. And then sedation, adrenal insufficiency, vomiting, loss of appetite, fatigue, weakness, dizziness, low blood pressure. It also has more drug-drug interactions than, for example, buprenorphine. So depending on what the client may have prescribed or is on for other medications, that would be important to consider. And then there's some other side effects. A lot of clients will report constipation. That's probably like the number one from being on methadone. But some will have some nausea, sweating, sexual dysfunction or decreased libido, drowsiness, amenorrhea, weight gain, and then edema is another one we do hear. I wouldn't say super frequently, but maybe next frequently after constipation. Drug-drug interactions. I'm not going to read them all, but here's a list of all the different kind of categories of drugs that you might not want to take with methadone. The biggest reason for wanting to not mix these drugs is, once again, the respiratory depression. So some of these also have that type of effect, so you wouldn't want to mix the things that have respiratory depression together. Requirements and regulations. So federally certified and accredited OTPs are the ones who are dispensing methadone for the treatment of opioid use disorder. There may be some loosening on that coming down the line, but essentially that's kind of where it's at right now. For dosing, the initial goal is to reduce the opioid withdrawal and the cravings safely. Okay, so everybody wants to do this safely. One of the biggest risk factors in methadone is during induction for death, right? So you want to make sure you use this start low and go slow approach. You want to increase the dose at a rate that minimizes the chances for continued illicit drug use, but you also want to be able to monitor for side effects. I will say Stonybrook probably has one of the slower induction processes than other places. We are very cautious about induction because it's the riskiest time for death. So we do have a very slow process. Dosing should be individualized based on the person. And you want to assess for sedation at the peak serum concentration, which is about 2 to 4 hours after the dose. So the goal is a dose that's going to stop withdrawal symptoms for full 24 hours, that reduces their or eliminates their cravings and blocks or blunts their euphoria from the self-administered illicit opiates. Okay, so when they get to like the ideal dose, that's what we're going to see. We're going to see that they don't have withdrawal symptoms when they're dosing, they're not having cravings, or it's greatly reduced. And that essentially, because they're not getting any euphoria from illicit opiates, their use of illicit opiates is decreasing over time. The first dose can be between 10 milligrams and 50 milligrams. 50 milligrams is new, brand new, April 2nd. They increased it. It used to be 30. Now they're going up to 50 as the suggested maximum. The patient needs to be observed for about 2 to 4 hours after the initial dose to see if that dose is sedating or relieving of withdrawal. So day one is really fun. People really hate coming day one because they're feeling horrible, and we're basically having them camp out here so we can like make sure that that dose is doing what it's supposed to do. If that initial dose is relieving, then the patient should return the next day and continue. If it's sedating, then the patient should stay under observation until the symptoms resolve. And then the next day, the dose needs to be reduced. If neither, after 2 to 4 hours, you can increase. But once again, you don't really want to exceed 50. And if you do, you have to be very careful and document very thoroughly as to why you're going to do that. So, you know, for example, if I gave them 20 and 2 to 4 hours, nothing has happened, it's not doing anything, then maybe I could give them another 20. But I would just want to be very careful about that, go slow and small increments. If the person's transferring from another clinic to your clinic, so they're already on methadone, then you can continue the dose that they are already on once you confirm it and it's documented. So I will say this is one of the things that in today's day and age, I'm surprised we still do this really old-fashioned way, but we have to call the clinic and verify, like the second they're at the window to dose here, we call over and we say, hey, can you verify the last day, the last time, the last dose that you gave this patient, to ensure that they are not getting a second dose on the same day that they already dosed. And believe it or not, this happens often where, you know, they say, oh no, I didn't dose today at that clinic. I'm coming to you guys today, ready for day one. And we call over and they're like, no, we dosed them. So I would love it if we come up with a better system someday. But in the meantime, we play the old-fashioned phone tag and try to figure that out. The initial dose for people who have these risk factors listed here should be about 10 to 20 milligrams. So if they're 60 and older, if they have lower levels of opioid tolerance, so like they're coming out of a facility or something where they haven't been taking opioids in the last few days or so, if they are using other sedating substances. So if they are using, for example, Xanax, which many people are, it's not that they can't do methadone, but it is that we want to be extra careful about the methadone and start at really low levels. Here at Stonybrook, for safety reasons, we do not permit our clients to be using Xanax in combination with methadone. If they are on it, we are going, like prescribed it, we are going to ask them to taper off of that and go on to something else that's a little less risky. And if they're using it illicitly, we're going to work very hard to try to get them to stop using that and do something different. And probably their doses of methadone are going to look lower than our other patients. And use of medications that can increase or decrease the methadone levels themselves. Some of them can mess with the effectiveness of the methadone and some of the drug-drug interactions. So that would also be one where we're going to go with a lower initial dose. And then any of those medical disorders that, like we mentioned before, can have sedating effects or heart problems or things like that. So any of these diagnoses, asthma, pulmonary disease, anything listed here, we're going to start with a smaller dose, lower dose, and go slower. From weeks 1 to 4, the goal is to avoid sedation at peak serum levels and gradually extend the time that they can go without any opioid withdrawal symptoms and cravings. So once again, it's kind of an individualized process to figure out what dosing we're going to do. Here at Stonybrook, we go very slow. So it is a complaint we do get, but you know, ultimately safety is a top priority. So we often are going up in increments of 5 milligrams every 4 or 5 days, something like that, which other places might go about double that speed depending on their own processes and policies. At weeks 5 and up, the goal is to avoid that sedation, eliminate the withdrawal and the cravings, and block or blunt the euphoric effects. And the dose should be stabilized by then or close to it. If the client misses more than 4 doses in a row, so they don't come to the clinic 4 days in a row in the beginning, they need to get reassessed and the dose is going to be drastically decreased. In fact, they may just start over. And so essentially their tolerance is now going to be different. We need to reassess and make sure we're putting them at a dose that's safe. It sucks that they have to do that for them because it's like, oh my God, I gotta start all over. Yes. But for safety reasons, you do. Here on day 3, after they miss 3 days consecutively, they get half the dose that they were getting before. And then after 4 days out, they basically start over. They have a doctor reassess them and determine where they need to start at. So just a brief overview of like Suboxone or buprenorphine in comparison. So buprenorphine does similar things. It reduces opioid misuse, HIV risk behaviors, and the risk of overdose death. The difference is it only partially activates the opioid receptors. So it is a partial agonist, binds to and activates the receptors sufficiently to prevent the craving withdrawal and block those effects of the illicit opioids. Like we talked about before, it typically has that level off spot where it goes up for a little bit and then it kind of levels off. It has the benefit of that ceiling effect, and it's available outside of OTPs. So although OTPs offer it, we do prescribe it here. They can get it other places, like a physician's office or other clinics. It's pretty readily available, so that's one perk of it. It can cause opioid withdrawal in patients who have recently taken a full opioid agonist. So depending on what they were doing prior to buprenorphine, you want to be careful of that. And the most common buprenorphine formulation does contain naloxone to help reduce the misuse. Not all of them do. There is straight buprenorphine, but some of them do have naloxone in there as well. There are 2 forms of it that melt on the inside of the cheek or under the tongue. They've got films that are combined with naloxone or tablets. You can have a combined buprenorphine naloxone tablet or just a buprenorphine tablet. And then they also have a long-acting implant and a long-acting injection. The implant itself lasts about 6 months if you were to do that. And the criteria for that, you have to be addicted to opiates. It could be for less than a year. Doesn't have to be a year, whereas methadone used to be a year. Now they've changed it, but that used to be a difference. And then basically any determination that this is going to be a helpful medication, you can do it. Contraindications, basically for people who are allergic to it or with any allergic reactions to naloxone itself. Risks, there are very similar risks to methadone, essentially. Pretty much most of it is the same. I think some of the side effects are a little bit different, but for the most part, the risks are pretty much the same. Drug-drug interactions, so there's a lot less, like I mentioned, than methadone. It's going to be some HIV medications, anticonvulsants, some antibiotics, anything that has this CYP433A4 enzyme inhibitor or reducer or inducer. So the requirements and regulations, like I said, OTPs can do this under OTP regulations. Other prescribers can do it in any medical setting if they meet requirements. There is some certifications that you would need to do if you were going to go ahead and start this, tomorrow or something. And the dosing difference, so the goal is to reduce or eliminate the opioid withdrawal and the craving without causing sedation. That's essentially the same. And you only want to begin this when there are clear signs of opioid withdrawal. The initial dose It's going to be 2 to 4 milligrams typically, or 2 to 4 milligrams, or 2 milligrams over 0.5, or 4 milligrams over 1 if it's that buprenorphine naloxone combination. Takes about 3 to 10 minutes to dissolve fully if you're taking that form of it. After 2 hours, you can give a little bit more if the person is still symptomatic. So very similar to the methadone dosing, where you're giving a little bit, checking, giving a little bit more if needed. Doing the same thing if there's sedation, where you're going to stop, reevaluate, and decide where you're going from there. You want to taper a patient to 30 to 40 milligrams of methadone and be on that level for about a week before you start buprenorphine if the person wants to switch. We do have people who do that, who want to transition off of methadone to Suboxone. So we want to make sure that they're going to be at a safe transition plan here. You want to make sure that between the last dose of methadone and the first dose of buprenorphine, that there's at least 24 hours, 36 would be ideal, but at least a 24-hour window between the two. For increasing for buprenorphine, when there's continued illicit opioid use, when they have continued cravings, continued withdrawal, or continued euphoria during the use. You can go up by about 2 milligrams to 4 milligram increments every 5 or 6 days, depending on the patient. And you don't want to go over more than 24 milligrams over 6 per day. But most patients are going to stabilize on that 4/1 or 24 to 6 milligrams per day. So decreasing is the same as methadone when there's any sedation or evidence of any dose toxicity. And you want to hold the dose when there's acute alcohol or benzo intoxication. Naltrexone, so they have oral forms of naltrexone. They've got the injection, Vivitrol is the other name for that. So naltrexone will stop opioids from reaching and activating the receptors. It's going to prevent any reward from use. It's an antagonist and doesn't activate them at all. And it also will block other opiates from activating them. So the con of that is, like, for example, if somebody was on Vivitrol and they had like a car accident, they needed, opioids for, pain, whatever. It would take a lot for them to override it. They definitely can. They just would need to know you're on Vivitrol, because you would need stronger pain medication to override. The naltrexone will reduce opioid craving, but it doesn't appear to reduce any opioid withdrawal. You've got to be abstinent from short-acting opioids for at least 7 to 10 days, and from long-acting for 10 to 14 days before it would be safe to take this, or you're going to be in withdrawal. So you're just going to have some very unpleasant effects if you were to get that prior to those windows. The oral naltrexone, those are tablets you can take. You can take those 2 different ways, either daily or 3 times per week. However, unfortunately, they're rarely effective. I mean, essentially, they're rarely effective because people typically stop taking them, or they just don't take them on the day that they want to use. So they don't have a great effectiveness overall. The injective form is obviously more effective because it's in their system for about 28 days. For naltrexone, you want to be addicted to opiates and have completely completed the medically supervised withdrawal process. So we know that you're not going to have any withdrawal symptoms. And naltrexone can also be used for alcohol. I should note here, just if people weren't aware of that, it will treat alcohol as well. And you also have to be willing to take a monthly injection or take the medication daily. So I mean, it doesn't really do you a lot of good if you have somebody who's really not medication compliant, who's not going to take the medication every day. Contraindications, any pain with opioid analgesics, any like opioid dependence at the current time, opioid withdrawal, severe hepatic impairment. If you had a naloxone challenge done, which essentially is giving just a tad bit of naloxone and seeing if there's a reaction, if that was done and you had a reaction, then that would be a contraindication for the medication. A lot of times too, doctors will start the client on the oral just to see if there's any side effects before they do an injection, because obviously if you took 1 day of it, it'll be out much quicker than if we put a 28-day injection and you got that in you for 28 days now. So that's also kind of a form of the naloxone challenge, is to give just a little bit and see if there's any reaction. And then any history of hypersensitivity to naltrexone or any of these other components that are in it. The effectiveness of naltrexone, it reduces the illicit opioid use and retains patients in treatment more effectively than placebo and no medication. That's specifically the Vivitrol version. The oral medication is not widely used for opioid use disorder because there's low rates of patient acceptance of that medication, high rates of non-adherence. And so typically it's not doing too much. It could be useful in settings where you're going to observe daily dosing, or like if they were in an inpatient setting or something, but essentially in outpatient, it's not typically too effective. Risks, if you take it after recent use of opiates, it can precipitate opioid withdrawal. We talked about that. Opioid overdose death. So the risk in that is essentially if you were trying to get high while using it and you were taking more and more and more, you're still at risk of overdose just because you're not feeling the effects. So sometimes people think, well, if I don't feel it, it's not going to do anything. No, it's still going to result in overdose, even if you're not feeling it. And people often will do things like that when it's at the end of that 4-week time where they're like, oh, it's wearing off. And so they might resume a dose that they were previously taking without realizing that their tolerance is different. And that can result in overdose. Injection site reactions, I would say that's the typical, most common complaint about it is any pain, tenderness, swelling, that kind of thing around the injection site. Hepatitis has been associated with withdrawal. However, that's often in the presence of other hepatic toxicity like alcohol liver disease or viral hepatitis. You want to use cautiously in patients with any moderate to severe renal impairments, and that's because the medication is processed through the kidneys. There can be some hypersensitivity reactions like rash, anaphylaxis, those types of things, depending on if you have allergies to it. Oral naltrexone has been occasionally associated with dysphoria, but that's kind of unclear whether it's a side effect or there are other causes. And then unlike methadone and buprenorphine, it has not really been researched in pregnant populations. So therefore it's not recommended for people who are pregnant. And other side effects could be insomnia, the injection site pain, hepatic enzyme abnormalities, and nasopharyngitis. In terms of drug-drug interactions, there's limited, and actually there's none listed in tip 63, which was put out by SAMHSA. So that is one positive. And it doesn't have any regulations beyond those that apply to any other prescription pharmaceutical. So any healthcare provider with prescribing authority can prescribe this. And once again, we prescribe it here, but you can get it at a PCP or other places as well. The dosing, if you're doing oral, the initial dose should be about 25 milligrams and then go to 50 on the second day and moving forward. If you're doing the 3-day per week option, then they suggest 100 milligrams for 2 days and 150 for the third day. And then if you're doing the injection, it's going to be 280 milligrams intramuscular every 4 weeks or once a month. So to decide what medication is best for your clients, you want to tailor your decisions to the patient's medical, psychiatric, substance use histories, to their preference, to the treatment availability, all of that fun stuff. You want to consider any response they've had to those medications in the past, the side effects, the safety and effectiveness, any use of other substances that they have going on, their occupation. So for example, methadone is not able to be used by people who have a CDL. They're not allowed to be on methadone. So that would be something to consider. Their pregnancy status and any physical dependence on opioids. If they're not physically dependent and they're returning to the community from like residential or incarceration, then you really want to think about which of those 3 best fits their needs. Pregnancy. So in pregnancy situations, you really want to make sure you're coordinating with all the providers involved. Methadone or the buprenorphine without naloxone is recommended because once again, the naloxone hasn't been studied well enough to know whether or not that would be safe. Naltrexone is not going to be recommended. Medically supervised withdrawal is not advisable. So once again, if you find out that you're pregnant and you decide you're just going to essentially get off opiates and not do anything, like methadone, Suboxone, etc., that can cause premature labor, it can cause fetal distress and miscarriage. So it's definitely something to really make sure they're talking to the doctor about to see if that's the right option for them. Attempts at abstinence without medication is generally not advised also because the risk of return to use is actually really high. And typically that can result in a lot of harm to the fetus. So you want to be careful with that. Newborns of women who take the medication, we talked about that, can often have NAS, and NAS is treatable. It's not as harmful as if they were to continue opioid use or if they were to relapse after a period of abstinence on opioid use. Mothers who are stable on MAT are still encouraged to breastfeed. So you can breastfeed while on methadone. Discussions around MAT should include, so if you're talking to your patient, you want to kind of talk about the effectiveness of the different medications compared with placebo and with just outpatient counseling without medication. You want to consider the risks and the benefits of the treatment with all the medication types. And once again, the same with treatment without medication and no treatment. And the safety and effectiveness of the medications when they use them appropriately, and pharmacological properties, routes of administration, where and how to access treatment with each medication. So, you know, for example, if I have somebody who's really not treatment compliant, is not going to go to a clinic every day, then methadone might not be the best option for them. But if I do have somebody who, you know, is really struggling with, you know, chronic intense use and is willing to take a medication every day and go get that, they might be more appropriate for that type of medication. But if they're not going to be adherent to going to a clinic regularly, then, you know, maybe Suboxone is a better option. So you got to kind of talk through that with your client about what makes the most sense. For treatment planning, obviously you're going to set treatment goals. You want to set conditions for changing or stopping treatment right from the get-go. It's really important for clients to understand, for example, methadone is not typically a short-term program or a short-term solution. So, you know, it's important for people to know from day one, kind of what the anticipated length of stay might be. I mean, they can always, you know, tailor that to their own decision. But it's important for them to know, for example, you know, at Stonybrook, we're going to require that you engage in counseling, and we're going to require it this often until this time, and then it'll go down to this often. You know, setting that from the very beginning can be very helpful. Setting therapeutic contingencies for non-adherence or failure to meet the initial goals. So usually this means we're going to increase the intensity of services, but I try to let clients know that on the front end so that they're not surprised when it's like, hey, we've been doing this for 4 months. We're not seeing a lot of change. We need to do something else. Whether that's, you know, IOP needs to happen or you need to go to inpatient or whatever. You want to set treatment agreements to clarify the expectations. So for us, that looks like letting them know our expectations regarding benzos and alcohol. We do have a benzodiazepine and alcohol policy that we go over with all of our patients of what that looks like. We let them know our expectations for urine screens and things like that all from the beginning. And then for buprenorphine specifically, I found this interesting. I don't know if other people know about this, but I say it's important in the treatment planning to set a goal to abstain from tobacco prior to dosing, as it can impact the absorption. So I thought that was interesting. Had not heard that before. Urine screening, the frequency, it should be random, but at least at the initial evaluation and the initiation of the medication. And then at frequency that's consistent with the office visits. We're going to talk about frequency of office visits in a minute. But they do recommend weekly initially. I will say we don't do weekly. We do, the requirement is a minimum of 8 per year for methadone. So that's your bare minimum that you got to do. We do typically 2 a month for our clients until they reach a certain level of take-home medication. So every clinic's going to be slightly different in how much take-home medication they allow their clients to have and when. Stonybrook does require our clients to come to the clinic every day, Monday through Saturday, in the initial phases of treatment until we can ensure that they are on a dose that is kind of helping them abstain from day to day. So essentially, we don't allow any take-home medication other than the Sunday take-home medication until they have had 2 urine screens that don't have other substances in it. However, there are plenty of clinics that will give you take-home medication day 1, 2, 3. So that's really a clinic decision and a clinical decision. Lab urine testing should be done periodically or when a client contests a result. We send most of ours to the lab, honestly, but that's up to the clinic to decide. Therapeutic approaches for patients on MAT. Experts recommend brief supportive counseling at every visit. So what does that mean? It's not necessarily a formal counseling session, because that would be a lot for somebody who's coming to the clinic 6 days a week. But essentially what we're looking for is are they managing their stressors? Are they able to identify their triggers? We're trying to provide empathic listening, non-judgmental discussion of their triggers and their cravings. We're providing ongoing assessment of their treatment goals. We're linking to any medical care for any comorbid health conditions. We're providing referrals. We're including and educating their family members and friends if they have people that they're willing to have us reach out to or talk to, and providing any advocacy on their behalf. So those are kind of the things we're trying to do in those initial days. The frequency of the visits, they recommend ideally 1 time a week or until stable. So it's kind of up to you to determine what stable looks like. They don't give very great specifics on that. But there are some things you can consider. So you can consider for less than weekly, several weeks of illicit opioid abstinence, adherence to their appointments and treatment plan, no alcohol or benzo misuse, absence of medication side effects, stable mental health and medical health conditions, responsible handling of their medication, absence of any PDMP concerns. There is nothing saying you have to have all of these things in order for this. It's just those are things to look at and maybe consider in trying to decide how frequently to see the client. The goals of the weekly visits. So this is more of your like therapeutic session, not just the check-ins at when they come to get their medication, but those are to assess clinical needs and challenges, assess the medication, their functional status, how they're coping with stress and triggers, if they're adhering to the medication, monitoring their use of alcohol and other illicit substances, and following up on whether or not they did any of the referrals that we gave them. Once again, these are some indications that they can come in less than weekly, but not requirements. So they don't have to check all of these to be able to come less than weekly, but there are things you might want to think about if they've been absent from illicit opioids, if they've been adhering to their appointments and treatment plan, if they have any ongoing drug use that may risk their safety. That's really referring to alcohol and benzodiazepine use. Absence of any medication side effects, stable mental health and medical conditions, responsible handling of their medication, and absence of the PDMP. Therapy interventions. So it's helpful to use motivational interviewing and behavioral treatment with contingency management. So essentially rewards for illicit drug abstinence. So you know, what can they, you know, get for working on their abstinence? For example, all of our clients who have had an entire year, so have been with us for a full year and have gone a whole year with no illicit substance use and have attended all of their counseling sessions, we give them a reward at the end of the year. So this last year we had 26 clients who had a whole year of illicit free substance urine screens and attended all their counseling. So we try to build in some things like that. We've also done some things where we've done like a passport kind of thing where they had a little passport, and you know, if they went to all their counseling sessions for the month and they did all their dosing for the month, they got like something at the end of that. So we try to build in some contingency management systems as we can. And then obviously peer support is always highly encouraged and recommended. And if they have consistent substance use, this may indicate that maybe they need a different medication. Maybe they need more like observation when they're taking their medication to ensure that they're taking it. They might need a dose increase. They might need more counseling or a higher level of care. Or maybe they just need other services. You know, maybe traditional counseling isn't the best way for them. Maybe they need more peer support. Maybe they need to go to, you know, outside meetings or something of that nature. So it's important to kind of look at what might be helpful there. And then if they want to taper or they want to stop using methadone, it's important to have combined and shared decision making. We want to talk about it. At Stonybrook, we have what we call a taper assessment that we do, where we go through and see if they seem ready for a taper, if they have things in place to, you know, succeed without it. And it doesn't, the assessment itself doesn't really say yes you can or no you can't. All it does is give us some talking points of things to consider, like, hey, you know, you mentioned you haven't gotten a job, or you don't have very much family support or friend support. do we want to work on that a little bit more before we consider tapering? Ultimately, the patient has the decision. So if they want to taper, they can taper, but we do try to do that assessment and have those discussions with them prior to tapering. If we see that, that might be important for them to consider. The risks and benefits should always be discussed, and we want to consider the following: whether or not they've been adhering to the medication, whether they've been able to abstain from illicit opioid use, their living environment, their social support, any improvements they've made in their functioning at home, school, or work. So our tapering assessment will kind of review all of those areas with them. And then from there, as the clinician, will kind of highlight, like, where they've done really well, and where maybe we should work a little bit more prior to them tapering, or maybe while they're tapering. Successful tapers take a long time. So typically a successful taper can take anywhere from like 1 to 2 years, depending on how high of a dose they're on. And a lot of times it takes 1 to 2 years is because they do often pause the taper, in terms of like, I'm starting to feel more cravings. I'm starting to struggle a little bit. I want to sit at this dose for a while before I resume the taper. So, we have seen that, generally speaking, if they go quicker than that, they're often disregarding some of the things that are coming up for them, and they often relapse. So important to kind of look at those things and encourage them that tapers take time. And if it goes quicker than that for them, that's great. But it can be helpful to set that precedent from the get-go that, that it might take a while to get off of it. And then you want to come up with that taper plan with the client. Once again, it would be looking at kind of those pieces of like, okay, how do we know when we should slow down a taper? The doctors will write orders for the taper. However, oftentimes it'll say something like, the client can decrease by 1 to 5 milligrams every 2 weeks, for example. So they kind of have some say-so and like, yeah, I want to go down 2 milligrams this week, or I want to go down 1 or 5, or not at all. So it's really important that when they're having some of those choices, that we are discussing with them what they want to be mindful of in making the decisions. And then considering that maybe, afterwards, do they want to follow up with some Vivitrol for a while, or, is Suboxone something they want to transition to first? There's other ideas and things you can use for a bit to help enhance long-term recovery. And you must make a meaningful referral prior to any forced tapers. So forced tapers are really discouraged. We don't do any forced tapers here at Stonybrook. The only time we'll see something like that is usually when a client decides rapidly they're done with it and they want to get off. And so they want to do a taper, and they want to do a taper today. That kind of look like this, and they're generally highly discouraged, essentially because, like we mentioned before, typically they're going to return to use pretty quickly and pretty severely, and so it's unsafe. So we really try to make meaningful referrals. We have clients, who will, for example, decide they don't like a rule at Stonybrook, they want to be done, taper me off today. We will really try to link them to a different clinic that has different rules that fit their needs, prior to, engaging with a taper. It can be difficult. I know I've tried very hard sometimes to make those referrals, and people are really resistant and they just want to get off, but we do have to, make our best attempt at that. And that's what I got. So I'll open up for questions.
Thank you, Marissa, for a great presentation. That was awesome. I will open it up for questions here. I had one kind of quick one. So you did mention switching, possibly, like if I was a patient who was on methadone and then wanted to switch to something like buprenorphine or Suboxone. I've talked to people who kind of get are slightly afraid of doing that switch because of something like precipitated withdrawal. Is that something that is like a common apprehension for people that are looking to switch? I'm speaking from personal experience. I'm someone in long-term recovery that's been on MAT in a former life, and precipitated withdrawal is very, very uncomfortable situation to go through. So when I saw that it was 36 hours at least from the last use of methadone, is that like the
Yes,
general
but
rule of thumb?
At that low dose though, so I think it was like 30 to 40 milligrams on methadone first. So you have to taper all. So if you were on, like, for example, 100 milligrams, you first got to taper all the way down to 30 or 40 prior to making that transition. So it would have to come down quite a bit. Like if you think about 30 to 40, that's like an initial dose of methadone. So it's a lower level. of methadone. I mean, I've kind of heard mixed things about it from people who have actually done the transition. I actually haven't heard too much complaint. I think there's a
Okay.
lot of fear involved in that. And for some people, you know, that discomfort maybe more than for others. But from the patients that we've had do it, I haven't heard as much. But typically when we're making that transition here, it's typically because the person isn't compliant enough with the methadone. So with the Suboxone, you can get more take homes right off the bat. You know, it's different in terms of its dosing. So they may not be on, you know, 30 to 40 milligrams consistently when they're making that transition. So a lot of things can impact it. So once again, that's why we got to individualize it and talk with each person individually and see what makes most sense for that person. Maybe that person should get all the way off before they transition, or, you know, maybe they've been taking it every 3 to 4 days, so it's not going to be as detrimental. Like, it just really depends.
All right, Felicia, I see your digital hand.
Hi, everyone. So I'm going to ask you a personal question, if you don't mind. So
Sure.
if it was your own child that was addicted to opiates for, let's say, 1.5 years and was walking in the clinic, what form of mat would you choose for your own child?
So I think that really depends on what level of addiction I'm talking about. I think methadone gets such a bad stigma and rep, and I felt that way before I worked in a methadone clinic, to be honest. I was like, all that. But essentially, for people who are very, very like chronic and intensely addicted to opiates for long periods of time, I think that it's methadone is going to be the best option. And primarily because I just see, like, you know, here we look at, like I said, like 26 people who, you know, were using heroin, fentanyl daily, you know, intense levels of it for years, and now have 3 years, 4 years where they haven't used anything but the methadone. You know, consistently we see really, really great results from that. But also, I think it depends on the program as well, because I do know, for example, you know, there are other clinics who give more take-home carries earlier on. And so if I had a child where I was really concerned about the mismanagement of that, then I don't know that I would feel comfortable with that. Like, you know, I would want to make sure it's a clinic that's making sure that they're going to take the take-homes the way that they are supposed to. You know, we've gotten a lot of transfers recently of clients from other clinics who say, yeah, I was only going to the clinic once a week. They were giving me, you know, 5, 6 take homes at a time. And I was drinking ahead. Like, I was taking like a methadone dose and a half per day. And so I was running out early, and I'm like, oh my God, like, no, we don't want that. So, I mean, I think there's just so many factors to consider. But in my like 15 years experience in addiction, I would say, like, there is a type of clientele that this works wonders for. And then there are other clients where Suboxone might be enough, you know, I mean, that might work just fine, and they might manage that medication appropriately, and that might, you know, hold them over. And for others, they might need something more like methadone.
Thank you.
Thanks, Felicia. We got time for one more question. I know Eric couldn't raise his hand, but he had a question for you. Eric, go right ahead.
Hi, how you doing? What if you're in this program and you have a co-occurring disorder, like a mental disorder, and you're taking antipsychotics or antidepressants, you know, SSRIs, stuff like that? How would you handle a case like that?
Well, a lot of our clients are on those types of medications. I think that essentially the difference between people who are on those medications and not would be how we're doing our induction process. So you're going to start on a lower dose, and you're going to move slower up than somebody else to make sure you're not going to have any drug-drug interaction, side effects, etc. So, I mean, that all happens through the doctor's orders and assessment. But essentially we have, I mean, I would say, you know, like 95% of the clientele have mental health disorders and are on other medications as well. So, yep.
All right. Thanks, Eric. And we are out of time. So thank you again, Marissa, for making the time for us. Great presentation. I'll make sure I put this up on our YouTube a little bit later, and we can share that. And then if anybody has any questions, feel free to reach out. But Marissa does great work over at Stonybrook. So if you or somebody you know is looking for some mat treatment, they are right over there in Wheaton. And if you need to stop by and get some Narcan in their little vestibule, we got our box up at the Stonybrook vestibule. So thank you again, Marissa. Thanks to everybody for coming, and we will see you next month.
Thank you.
Bye, all.